Hi there, and welcome to this short presentation on the echocardiographic assessment of right heart function. My name is Andrea Robinson. I'm one of the critical care ultrasound fellows at the University of Alberta in Edmonton. This video presentation is part of a series on the sonographic assessment of right heart dysfunction in the ICU, and I have no specific disclosures to report. As a reminder, last time we spoke about some of the ways you can interrogate pulmonary pressures in the bedside echocardiogram. Today, we'll look at some of the downstream effects on right ventricular function and talk about some of the markers of RV dysfunction. Although there are more of them, they are conceptually simpler to understand and rely on more basic two-dimensional and one-dimensional imaging, and so we'll be able to move through some of them a little faster. For the most part, the concepts shared here are drawn from and consistent with the American and British Societies of Echocardiography. It's important to remember that our goal here is not to cover all the ways to assess the RV, just the basic validated ones that can be used at the bedside. Finding these signs at the bedside does not replace the need for a comprehensive study if otherwise indicated. Merely these are signs that we can rely on at the bedside to guide diagnosis and management of critically unstable patients. There are a few ways to conceptualize acute right heart dysfunction in the critical care setting. However, this 2018 paper by Dr. Antoine Vieillard-Baron and his colleagues provides a very helpful framework, and I would encourage anyone with an interest in acquired right heart dysfunction to take a look at it. Dysfunction of the right ventricle can be conceptualized as a problem of poor contractility, pressure or volume overload, or some combination of the three. Poor contractility in a general critical care setting is most commonly due to the effects of hypoxia, acidosis, or global myocardial dysfunction in the context, for example, of severe septic shock. Volume overload can often be a consequence of aggressive IV fluid resuscitation or acute tricuspid regurgitation, for example, from infective endocarditis. Finally, pressure overload can be conceived as anything that will increase the afterload of the right ventricle. This can include exacerbations of chronic pathologies, like underlying chronic pulmonary hypertension, or acute dysfunction due to the presenting pathology, such as mechanical obstruction to flow from a pulmonary embolus. Or it can be a consequence of the therapies undertaken in the ICU, such as positive pressure ventilation or increased pulmonary vascular resistance from vasopressor administration. Our focus today is on the signs we can look for on echo to assess the function of the right ventricle. So let's talk about some of the windows we can use to assess the RV. These will likely already be familiar to you. We can use the parasternal long axis, which, although very LV focused, also gives us a view of the right ventricular outflow tract in the near field and can give us clues about RV size and free well function. The next is the short axis view, both at the level of the base, shown here, and the mid-papillary level. This gives us an excellent view of the outflow tract at the level of the base, and at the mid-pap level gives us important information about RV size and septal movement. Next, let's talk about the apical forechamber. This is the view that will most commonly be discussed when assessing the RV, and many of our assessments of size and function will be taken from this view. By sliding and rocking the probe slightly more lateral than the true apex, you can bring out the so-called RV focus view, shown in the diagram here, and that allows a very complete RV assessment. Finally, the subcostal forechamber is an easily acquired view that offers the same visual information as its apical analog, although many of the measurements will not be possible from here. So let's get to it. One of the most discussed features of RV function is its size. The right ventricle is generally far more compliant than the left, and so can enlarge very quickly when confronted with changes in preload or afterload. A normal RV base will measure 4.2 centimeters or less. An easy rule of thumb is that the RV diameter should be 2/3 or less than that of the LV. If the RV is approaching the size of the adjacent LV, it is mild to moderately enlarged, and if it is larger than the LV, it is severely enlarged. In this example on the left, the right ventricle is of a normal size compared to the much larger left ventricle. The RV in the clip on the right is markedly enlarged in comparison. You can see that it is larger than the LV. two important features to look for here are the presence of the moderator band that you can see about midway up the RV in this clip, and it is often quite well seen in enlarged RVs, as well as the positioning of the tricuspid valve, which is generally slightly higher in the near field than the mitral valve. Both of these can help reassure you that you really are seeing a large RV and not that you unintentionally inverted your probe. Moving on to the function of the RV, we won't go into any great detail about RV physiology, but suffice it to say that there are three components to RV systolic function: free wall movement, longitudinal contraction, and traction movement from vigorous LV movement. Longitudinal contraction receives a lot of attention in the point-of-care world because it is one of the first things to be lost in acute right heart syndromes. The easiest way to assess it is to look at the tricuspid annulus plane systolic excursion, or the TAPSE for short. This looks at the longitudinal movement of the tricuspid annulus during systole. To measure it, you place an M-mode line right over the tricuspid annulus and then follow it over time. Vertical movement greater than 1.6 centimeters suggests a normal functioning RV. In this example, a TAPSE of 2.5 centimeters suggests brisk systolic function. The same concept is used in tissue Doppler imaging of the tricuspid annulus, where the velocity of the tissue at that point is measured. If tissue Doppler imaging is part of your echo assessment, then you can look for a TVS prime greater than 10 centimeters per second. Next, we'll look at the movement of the RV free wall. This contributes a major portion of RV ejection fraction. A visual assessment showing clear movement of this wall suffices to tell us that the right ventricle is functioning. However, if you're a numbers type of person, you can also assess this via the fractional area change, or FAC. Because the anatomy of the RV is dramatically different from that of the LV, you cannot use the same assumptions, namely those of a conical structure, to estimate ejection fraction. RV stroke volume quantification and ejection fraction estimation is a complex assessment and well beyond our scope today. Instead, what we look for is the change in area of the visible area of the RV between systole and diastole. Most point-of-care machines are capable of this estimate. Essentially, you trace the RV area, as seen here, that's visible during diastole and again during systole. The change in surface area during one cardiac cycle, calculated as a percentage of change, represents the fractional area change. A FAC of less than 35% suggests impaired RV function. Next, we can look to the opposite wall, namely the septum. This can be assessed in the apical forechamber and in the short axis view, but it is easier to quantify in the short axis. Essentially, what happens is that as the pressures in the failing RV rise, they overwhelm those exerted on the septum from the LV, which normally are higher, and the septum stops bowing towards the RV and instead flattens out. You can see that very nicely in this example here on the left. You can see that the septum has flattened out and that the LV cavity, instead of looking circular, resembles a D shape, a term you may have heard before. Noting which phase of the cardiac cycle this occurs in can give you clues as to whether the RV is pressure overloaded, volume overloaded, or both. When the septum flattens in systole, the contracting ventricle is exerting high pressures against a high RV afterload, and the ventricle is said to be pressure overloaded. Flattening in diastole, or during ventricular filling, occurs when there is excessive volume contributing to high preload, and the ventricle is volume overloaded. If you want to be able to quantify this, you can measure the eccentricity index by measuring the two diameters of the LV. In the normal setting, the LV is circular, and the ratio between these two diameters approaches 1. As the septum flattens, however, D1 shortens, and the ratio of D2 to D1 increases, generating a high eccentricity index. This gives you a numerical quantification of the visual concept which we just went over. And finally, the third part of RV systolic function occurs because the RV is tethered at the apex to the vigorously contracting LV. The force of LV systole is so powerful that it exerts traction on the RV, pulling it along with it. Although this is only a small contributor to RV stroke volume in the normal setting, it is important to recognize that it can be the only motion left when there is acute pulmonary hypertension and the remainder of the RV is shocked. This represents the famous McConnell sign, which, although classically associated with pulmonary embolism, is more accurately representative of acute pulmonary hypertension and associated obstructive shock. The adjacent LV is often hyperdynamic to compensate for its poor preload, generating the traction motion that we see in this image. So, between all of these, we have an array of tools to assess RV function at the bedside in the ICU. Here are some of the references used in this talk. I'd also like to extend my thanks to the following individuals for allowing me to use a number of their images and clips in this presentation and for their input. In our next video, we'll go over a few cases of pulmonary hypertension and RV dysfunction in the intensive care unit and review how a bedside echo assessment helped guide management. Thanks for your attention.